Welcome to Session 4, called Seeing the Source, Advanced Mapping and ICE in PVC Ablation. We welcome our case presenter, Dr. Fermin Garcia from Pennsylvania Hospital in Philadelphia. We also welcome our session panel, Dr. Andrew Davila from Boston and Dr. Usha Tedrow from Boston as well. Now, let's hand it over to Fermin.
Good afternoon. Thank you, Devi, for the introduction. I'm going to discuss the title of my presentation, Seeing the Source, Advanced Mapping and Intracardiac Echo in PVC Ablation. My case is going to be a 76-year-old male with history of high blood pressure and coronary disease, old, stent to the mid-LAD. He was referred to us for a second ablation of highly symptomatic, mild left ventricular dysfunction, high burden of PVCs. The whole idea of the case was hypothesized to be an idiopathic PVC, and the 45% was supposed to be a mild component of PVC-mediated cardiomyopathy. As such, a patient was referred and did not undergo a cardiac MRI. To the right side, you can see here the sinus rhythm beat, and you can see the PVC, not much abnormality on the sinus rhythm per se. The PVC, it's a right bundle branch block PVC that starts to transition around B4, B5, and interesting enough, it's completely negative on B6. It's a superior axis PVC and wide and notch. The assumption was on the first case that this was located somewhere around the papillary muscle, and the patient had some radiofrequency ablation, which failed. The first part of our case always starts with intracardiac echo, and this is the standard view of intracardiac echo. You see the right ventricle, the mitral valve in this area, and looks pretty good. Now, the idea of using intracardiac echo for these cases is you have a hypothesis. This PVC is somewhere inferolateral in the left ventricle. I want to focus on that area to try to see if there is anything that would suggest a good target for potentially mapping the side or the best side of activation. This is a standard image. The standard image is eyes from the right ventricle. And if you're interested in this area, the farthest area from the imaging probe, you have to go through the septum, see if to have a pacemaker and ICD, try to focus here. I had ventured to say that maybe in my mind, there might be something down here in the left aspect of the left ventricle, but overall, nothing jumps into the picture. Now, as we have run more and more, and this is the idea of imaging the source and advanced techniques, this is the same patient with the same probe, and now I have transeptally advanced the intracardiac echo into the left side of the heart, cross the mitral valve, and this same area you were seeing here now, it's well seen. And you can see there is an area next to the mitral valve of myocardium that doesn't thicken as good as the rest of the heart. In fact, it's thinner than the rest of the heart. And you can see that there is hyperechoic areas. And you could also see in the more epicardial aspect of this, perhaps also some linear hyperechoic area. So this starts to me like the perfect aspect to start mapping at the beginning. So this is the setup for our case. This is live PRUCA, as you know. This is review. In this case, we have a catheter going retrograde into the lateral atrium, left ventricle. This is the ice cut of this area, so you can see the image. And we have the catheter trying to get the best space map and the best activation. And all we could call was for the bigger area or a wider area of activation. And you can see that we performed several lesions in that area, all monitored by intracardiac echo. You can see the lesion formation, and we covered this area with radio frequency, and we had no effect. The PVC continued at the end of those lesions, we didn't do anything. So we had prep for considering alternative technologies in this, and we use Afera, but not with a ventricular setting, so atrial settings. You can see here again an intracardiac echo. So the beauty of using sound is that if you have your image coding plane in the area that you want to focus, you can see perfectly the image that corresponds to that area. So I can tell you exactly where my lesions were. And you can see in eyes that region. So we advance the fear eye supported by a long SL1 in case there is any difficulty moving the catheter at the moment of extracting, we can push that sheath all the way down. And again, we just mapped the area of interest, and it was similar to the area of interest we had before. And if I were to stop when we see a PVC, that's just ectopy, okay? And you can see that there was nothing really that would jump into mind for being early on the endocardium. So maybe precurous, decent pace map, but not perfect pace map. And you can see this is a catheter-induced. The morphology is not even close because the PVC is QF in the inferior leads, which obviously should start making you think that there's something else. At the end of the process, we kept mapping, and then we decide that it was a decent area, and we anticipated that we were trying to access areas of deeper tissue. This is the best activation we get, maybe 4 or 5 currents, and then we decide to apply. So we apply RIF, and then we start with PFA. Now, interesting enough, we had some effect. The PVCs kept coming back. So we did 3 applications in total. And the rationale for this is because I was concerned of the thickness of the tissue, and I was not sure that I wanted to do too many ablations because I was afraid that this could be a problem. Now, to be honest with you, at the end of these applications, things look pretty good. You can see here that after the RF and the PFA applications with Afera, the patient had no PVCs for a while. And this is just so you see an intracardiac echo. What we do is we circle the area of this with cartosound, and you can see these round reds are RF lesions and then PFA lesions on top. And this is the representation of that area of scar, which we have designed as a separate structure. What is very nice here, as you can see, is the catheter contact. And what you're seeing is a catheter is going into some sort of cavity and a thinner muscle, and you're trying to access it. Well, unfortunately, we have PVC recurrence at the end. An important concept at the end we will discuss is I do program simulation on patients that have some sort of a scar. And in this particular patient, you can see the patient is inducible for monomorphic VT. So even with an EF of 45, 50%, idiopathic PVC suspicion, this is not a normal heart. If you can induce this type of ventricular tachycardia, this is a problem. This is a problem in terms of prediction of sudden death. So patient stays in the hospital. We did not go epicardial at that moment because we had not talked about it. I was assuming this was going to be an endocardial PVC. And then here you can see the MRI. So this is MRI after the case. And you can see a whole area here of a scar, essentially. I don't know what happened here. I can move the slide. Okay. I want to show you this. This is the lateral aspect. You can see how we were going lateral. These are the lesions with the lattice tip catheter. You see a lateral area of scar. This one in the center, you can clearly see that area. And it's very, very basal. As you move towards the papillary muscle, it disappears. The patient continue having PVCs, and these are the different morphologies with different exits slightly from one to another. So we decided, listen, based on this must be epicardial. Now I want to show you the first step on the second procedure. In this case, we performed venography, okay? And I had tried to do this on the first case, on the first part, but we went directly, and as I thought, this was not going to be close enough. But at the end, what I did is I placed a mapped catheter in this lateral branch on top. You can see briefly, there's a lateral branch coming here. And then nicely, in the same agilus, you can put then a 4 French catheter. And with one catheter, I can put, with one sheath, I can put 2 catheters to my veins. So I directed that to remove 4 French here, and I placed an epistaral in the medial cardiac vein. Here's the activation here. The middle cardiac vein, as expected, is way, way late for the PVC. But look at the activation of this portion on the mapping on the lateral branch, very basal. Now we find something that is a little bit precurious. So this is indirect evidence plus two failure of endocardial ablation that we have to go somewhere else. So this is now the same patient with no vision nav. So in different technology for video imaging, you can have orthogonal views and look at the quality of the image for that area of scar in there. Very nice. And then that's how we guided our second procedure. So at the end of the day, what we ended doing was map the epicardium, map the veins, map the endocardium, and you can clearly see here the lineup of the activation. You have small areas of late potential here. There is early activation on that area on the epicardium, which beats the mapped catheter, which is a little bit higher, and the endocardium with the good unipolar is not even close to the earliest activation. So I have lined up all the signals here for you. And then the challenge here was contact. And this is the last point of my discussion is going to be in right here. You can see on eyes this beautiful image in which you have a big fat pad covering the whole basal portion of the lateral LV. You have the epicardium and you have the mitral valve with the area of interest. Now look at the tip of the eyes. You can see it right there. It's in between the angle of the fat pad and the muscle. And that was the area that had the best area of activation and pace map. It was, as I just showed you there, that was the coronary angiogram, say from the distance, and then right there after careful mapping, we decided to perform ablation. And you will see here that when we find the best area of activation there on the epi, we apply RF, and once we apply RF, the PVCs went away, and what you're having is a completely different PVC. So it was really complete elimination. So this was the area of interest, and we were activated. Now, I wanted to look at this map of activation, and it would suggest that there is a line of block here. And this might be good for Andres' presentation, because I want to just say that this is very important. Because look at the eyes picture. This is the line of block represented here. And this whole thing is fat, covering the very basal aspect. This was the best activation, and it was a 97% pace map for that PVC. And that was very nice. Now, I want you to focus here. This is the tip of green marker of your catheter. That's the only area you can map here. So if something is coming more basal on this region, you're going to be in trouble because you have no access to this area of the basal left ventricle. And these patients' VT probably were periannular, and they had a second morphology that was inferior access, very similar to what happens in Chagas on the base. And this area is inaccessible to you in the epicardium. You can go and explore as much as you want. You won't be able to get basal enough. So I decided to call this the inaccessible region of the lateral left ventricle. It's almost like LV summit, but in the lateral LV. And this is a big limitation, because look at this huge area of scar. This is not scar. Our catheter green tip is on top of a fat pad. This blue thing is the coronary sinus. And then you have obviously the epicardium. This fat pad protects this whole area of lateral left ventricle, and you cannot reach here. So when you're mapping these cases and VT, we say, well, is it really intramural? Why are we failing on this fast, very basal left ventricular VTs? We cannot find anything early. We cannot find late potential. This whole area is fat. And you would suspect that because it's low voltage, etc. You cannot capture. But the difference is direct visualization. And that's the whole point of this, is high advantage, taking advantage of eyes in this area for visualization. So non-typical PVC, open the discussion. Is there underlying substrate? It's always very important to define. I think the general concept here is the closest to the area of interest, the best quality. Excellent resolution. And I would like to open the question, is this better than MRI? Because we can use it in the EP lab. So you just need how to use the tool. But it could be much better resolution in terms of substrate definition with the arrhythmia correlation. And defining the area scar, I think it's very important. What if there's no area of slow conduction and all you see is low voltage and you cannot capture is a fat or is a scar. And this is a new concept that I am aware of. Just like you have LV summit, the lateral left ventricle and the proximal portions in general have the fat, but I believe in this lateral region of the left ventricle, that region is larger in some patients. So we're going to rely on better, more potent tools to try to target from the endocardium, or we could consider alcohol if there is any veins on this region. But I think this is a reason for failure today on VT ablation on the lateral left ventricle. And I always consider in patients with PVC that are non-typical and you question what's going on, program simulation for risk stratification is still an important tool. Thank you very much.
Thank you, Fermin, for that excellent presentation and opening our eyes to ice is what I'll say. Usha, let me start with you. You have the privilege of educating a lot of fellows and bringing the next generation of VT specialists to the field. In the world of PVC ablation today, what do you think is the biggest barrier in us truly seeing the source? Is it limitations in our mapping technology or just the operator's ability to integrate things like ice anatomy, like Fermin showed, and MRI imaging, if at all we do that, into a unified kind of accurate representation or interpretation?
I think the reasons for failure are multiple. Just like Fermin was showing in this case, I think we have mapping problems where we can't necessarily put our catheter right on the origin of the PVC when we're looking at a PVC case like this. I think when we did our needle catheter mapping of these types of PVCs, if you can stick a needle catheter in there, we often see sites on the endocardium or epicardium that are like -30 or something. But I was really impressed that when you have an intramural mapping source, you can really get very, very early areas of activation that aren't accessible either from the endocardium or the epicardium. So I think that mapping is a really big problem. But then also what Fermin was just showing about all the fat over there, we have a really big problem delivering lesions there too, because the more you get over that epicardial fat, probably the closer to the coronary arteries that we're going to get. But also there's going to be this insulation problem with delivering RF. And I've had this experience, which I think was the case in this case, maybe you could comment, that there's sort of stunning initially of your PVC and you think, oh, this is so great, I think I got it. And like the next day, their PVC is back, maybe slightly different because you didn't get transmural lesions. So I think on the lesion generation side, we have problems. On the mapping, we have problems, and we have to be like really careful anatomists in order to do these kinds of cases.
It's a great point, and I think there's so much more for us to understand and learn in this field. I have to say that a lot of resources have been allocated on the atrial side, and there's so much more that needs to be allocated on the ventricular side. Dr. Davila, let me ask you a question, and this is more catered towards things like pap muscle and LV summit PVCs, which I think are the most challenging. When Fermin says it's challenging to him, I'm worried about the rest of the world. I think this is where mapping deceives us, like he showed. And are there things on eyes that specifically kind of tell you which is the correct vantage point? Is it endocardial? Is it epicardial? Do I go to the cusp? When should I not even consider it? Is it a no zone, like Fermin said? Is a no access zone? Like what are things on that you look for? Andre, you're muted.
So when I see a negative V6, QRS in V6 in a very basal, otherwise PVC, I get worried. I don't understand the whole activation. And this is when you have to take all the tools that you have, including pre-imaging information, because I think that can help a lot when things don't line up, like what Fermin was showing, right? I think if you have like a pre-procedure MRI or even a CT sometimes can be very helpful for the planning of the procedure. Perhaps if we had some, and I totally agree with what Fermin did, I wouldn't go too crazy in terms of pre-procedure imaging this particular case. But now we know that it would have been more helpful if we had that MRI before the first procedure that he actually did. And I think you have to combine all of this. I'd just like to take a moment, if I could, to talk about this epicardial fat business. So the problem with the epicardial fat is extremely variable, and there is no body habitus that can predict this distribution of fat. You can have very obese people with the minimum amount of epicardial fat and the other way around. The problem is that if you go up to 5 millimeters of fat, you cannot differentiate areas that are covered up to 5 milliliters of fat or areas that are not covered by fat. The problem is that when you go more than 5 millimeters, and this is when you're going to get like low voltage, when you got to have this far field kind of electrogram, and then you know that you're in trouble because you cannot burn through 10 millimeters of fat. You cannot burn. It doesn't matter how much energy, RF energy that you're going to deliver, you cannot do that. And as Fermin said, it's inaccessible. You can't do anything about it. So perhaps a vein ablation or with alcohol vein ablation would be the way to go. But these are cases that are very difficult. And in this particular situation, it was good that, the location for you to ablate was like a few millimeters beyond the limit of fat. Otherwise, would have been a very tricky situation there.
Yeah, it's a great point. For me now, I'm going to ask you kind of the final kind of closing question here. I mean, you have been the master of ice, and you've trained a lot of us on how to use ice in the ventricle and what to see and what not to see, and what to watch out for. What advances do you foresee, whether it's AI or AI-based ice reconstruction models that will allow you to kind of synchronize all this real time? Because I think it's great to have pre-imaging. It's great to be able to see it, but sometimes people don't interpret things the same way. And I think that's where AI has stepped in and, taken it out of our eyes into depicting things in a different way. Do you feel like there is a future to that? Do you feel like it's going to change how EPs practice PVC ablation strategies?
Yes, I'd say that's a good thought and a good question. I think that anything technology brings is potentially going to make our procedures better. Certainly for a beginning of PVC mapping, I think the key of AI for this type of situation is going to be the integration of imaging with the basics, which is the 12-lead EKG. I think by doing that with AI, you would do what we're doing now. So if you look at this PVC, you're going to focus on the lateral aspect of the left ventricle. So hence, you would try to do a better reconstruction. The little experience we have now shows that you can have AI, and AI can guess when you're not seeing the tissue by imaging. What I'm trying to say is, if the image quality is not good, there is no AI. Because if you cannot see it, how can you are going to reconstruct it? You might guess based on AI, but that doesn't mean anatomy has to fit to your estimate. So I think before we apply AI and combine AI with EKG, which is probably going to be very useful, particularly for the simpler cases, I really think what's I'm impressed with advancing is with new imaging technologies. And I think that, for example, this last catheter we used, the beauty of putting the catheter there, and you don't have to manipulate it that much because you can simply rotate the tip of the catheter, and you want to go a few millimeters right, left, up or down. It's great because the amount of effort you have to do to get that image is going to decrease, which would make it, technically speaking, something that can be reproduced because you have a better tool that is stable and you can do minor adjustments. I think can also bring that less experienced operator to a better quality image acquisition. So I think AI is going to be good. The reconstruction is going to be good. The integration with EKG for PVCs will guide you to the area you want to map. But ultimately, before we go there, I think imaging technology has to precede that. And then the concept of how can you get your very image? If you're looking at a left pulmonary vein through a thick septum, AI cannot be perfect. However, if you now are inside and you look from the left atrium, that pulmonary vein, or from the left ventricle, this papillary muscle, that raises the resolution to an MRI level type of quality.
Well,
Devi, can I
that Yeah, go ahead, Andre.
I completely agree with Fermin because I mean, when I look at my image with ice, which of course I have 1% of Fermin's understanding of ice, I've been from very excited to very disappointed in terms of predicting the epicardial origin of circuits in VTs. Sometimes you believe that you have a clear epicardial circuit, you go epi, nav, there is nothing there. So I think you got to improve the image quality and add some sort of software to help us guide our strategy based on those images.
Agree. And on that thought, I think I will bring this session to an end. Thanks to Fermin for such a great case, and Andre and Usha for your wonderful thoughts. The next session on bipolar ablation starts in just 1 minute.